This video is on anticoagulants. So the main goal of anticoagulants is to avoid clots in the veins. Different medications are used whether there's a clot forming in the artery, moving away from the heart, or whether the blood is moving towards the heart. So our main culprits of clots in the veins are DVTs and PEs, deep vein thrombosis, and pulmonary embolism, so a clot in your lung or anywhere else in your body in a deep vein. And there's 5 different categories, 5 different classes of medications that we're going to take a look at that help thin the blood out, and different ways that we monitor how thin the blood is. And then all of this green here are the antidotes, because sometimes if you give a medication that's going to thin the blood, then you're putting your patient at risk for bleeding, because you're trying to stop clotting, so you're stopping all these different molecules, but then you might be more at a risk to start bleeding. And so if they do, you need to know the exact medication that will reverse those effects to stop the bleed, and we want to prevent even having to use these antidotes, so that's why we're going to be monitoring how thin the blood is, so we can prevent clots and prevent bleeding at the same time. It's a fine balance for this. That's why we need to have those antidotes memorized. So let's start with heparin. So heparin is very commonly used, and you need to report if there's any blood found in the urine or stool, because that may indicate a need for the antidote of protamine sulfate. And heparin is safe with pregnancy, unlike warfarin, which is unsafe with pregnancy. And what we're monitoring for heparin is the APTT, and the goal is to be 1.5 to 2 times higher than the normal range that you'd see with APTT. And we're going to just jump over to warfarin here because there's some similarities. They're unsafe with pregnancy. Warfarin is unsafe with pregnancy, and likewise, the goal is 1.5 to 2 times higher INR this time than what's normal. A normal INR is around 1 or 1.1, but we're going to be increasing that because we want the blood to be more thin than it normally is. And you may even want to be extra thin, so up to 2.5 to 3.5 more times more thin than normal. In the case of someone who's having recurrent emboli, which are clots that move, and then or somebody who has had a mechanical heart valve replacement. And so it's good when you're studying for these to get the big picture of everything, is to compare between the different classes what works for one thing that doesn't work for another. What drug is really effective for a particular condition, like having a mechanical heart valve replacement, that might be contraindicated. So we'll compare this to direct thrombin inhibitors. This is our 5th class here. Those are not good for artificial heart valves because platelets stick to them. Platelets like to stick to those artificial heart valves. And so now we can move on to low molecular weight heparin, and the reason why we often give these are because they're cheaper. So you might hear of somebody saying, oh, I have Lovenox shots. That is a low molecular weight heparin called enoxaparin, and all low molecular weight heparin drugs end in parin. Enoxaparin is Lovenox, and they're cheaper than heparin. That's why they're used. And whenever you're on heparin, the goal is to transition from IV to oral use. And with warfarin, we are going to be giving it in the evening because blood draws in the hospital are often taken in the morning, and so you don't want to give someone a drug that is going to thin their blood and then have to go and draw their blood out. You're going to just be bleeding a lot and it'll be messy. So we're going to avoid that by giving heparin in the evening time. And it's cheaper. Warfarin is cheaper than other drugs given for AFib. So you give warfarin for DVT, PE, or AFib, or mechanical heart valve replacement. So again, we're monitoring INR with warfarin, and we're monitoring APTT with heparin. And in all of these, we're going to want to be avoiding bleeding. So we're going to need to do things like avoid using razors when shaving. So you switch to an electric razor, and then make sure your toothbrush is a soft bristled toothbrush, and just avoid things that might cause bumps and bruises. And the antidotes for both low molecular weight heparins and warfarin is vitamin K. Vitamin K will thicken the blood, and so it's important to teach your patient to eat a consistent amount, to inform them of what foods are high in vitamin K, and to continually eat just a consistent amount of vitamin K rich foods, and don't be fluctuating that amount, because that will affect their blood. So maintain their same diet when they're on those drugs. And then our two other classes here, we have factor Xa inhibitors, and then we have direct thrombin inhibitors. Both of these relate to the coagulation cascade that we have, where the blood is trying to form a clot. In that process, there's a lot of molecules involved, where you have molecule A turning into molecule C because molecule B has come along and transitioned it. And that molecule C that we have now is going to change molecule D into molecule E. And everyone, it's like a step ladder. It's all dependent on the previous one. And so factor 10 is one that is a really big, important factor, because it's where the extrinsic pathway and the intrinsic pathway combine to form this common pathway to forming that fibrin mesh network of the clot. And so the extrinsic pathway is where you have an injury to the blood vessel from the outside. Intrinsic is from the inside of the blood vessel. And so factor Xa inhibitors is just a certain checkpoint in that coagulation cascade that we're stopping, and our main drug for that is called fondaparinux sodium, and it's for DVTs and PEs, and it has there's a few things to know about it. We have 4 different things to know about fondaparinux sodium. It has a longer half-life than heparin. Second thing is that it does not interact with platelets. The third is that it does not inhibit thrombin like our DTIs. And then fourth, it is similar to low molecular weight heparins in the way it works. So the antidote for this is andexamet alpha, and many of these drugs that are factor Xa inhibitors, inanabin and apaxabin is one of them, and the brand name for that is Eliquis, that you might have heard of. And you might hear in commercials, Eliquis has less major bleeding than warfarin, and which is true, and it causes less events for patients with AFib. So less strokes, things like that. And then we have direct thrombin inhibitors over here. And so this is our final class, and there's different endings for these drugs. One ending to know is that ends in rutin. So desirutin is the desired drug when the patient cannot tolerate heparin. We can switch them to that. And that's given sub-Q. And bivalirudin IV is given IV. And direct thrombin inhibitors can be beneficial in that there's no regular coagulation monitoring like we have for heparin and warfarin, where we're going to be wanting to see how thick the blood is, monitoring APTT and monitoring INR. And the antidote for direct thrombin inhibitors is iduricizumab, or its brand name of Praxbind. So, one thing to know about these, many of these medications will be given subcutaneously, so into the fat tissue underneath the skin, but not so deep as the muscle. And so you're going to be teaching your patients how to give themselves these shots, like Lovenox shots. Somebody might have to do that. And so it's given in the abdomen, and they're just going to kind of squeeze a little bit to make sure it's going into the fat, but you want to make sure that it's away from the belly button, because there is a muscle that's like goes right around the belly button that you want to avoid injecting it into. And when you inject something subcutaneously, inject it at a 45-degree angle, so it's not going so deep that it's going to the muscle, or so shallow that it's still going to the skin. Right at 45, we'll get it right into the fat tissue, which is where we want it to go. And that way, the medicine will be in the fat, and the body can slowly absorb it at a regular, consistent rate. And so that summarizes our anticoagulants. And this is one way that we can improve blood flow in patients who are at risk of clots.